Hello, my name is Dr. Tony Smith. I'm the Medical Director for St John, and in this video we're going to be talking about finger thoracostomies. A finger thoracostomy is an additional or alternative technique in addition to our Turkle needle, which we're still going to be using, an additional technique for decompressing a patient's chest if you believe the patient has tension pneumothorax. So finger thoracostomy doesn't remove the need to understand how to decompress a patient's chest using a Turkle needle. It's an additional technique. The general principles of a finger thoracostomy are to locate the fourth or fifth intercostal space and in the mid-axillary line to make a 3 to 4 centimetre incision with a scalpel. And the scalpel is used to incise through the skin and the subcutaneous fat. Once that's done, the scalpel is then put down, not put into a sharps container because the scalpel may need to be used again, and then from that point a pair of blunt forceps are used to dissect through the intercostal muscles, and often you'll feel the forceps then just pop into the pleural space. At that point we're going to put the forceps down, again not into a sharps container because the forceps may subsequently need to be required to be used again, and then at that point we use our finger, hence the term finger thoracostomy, and you use your finger to dissect through the intercostal muscles, and then you'll feel your finger pop through into the pleural space. You will know when your finger pops into the pleural space because it's a very distinct feeling. If there's pneumothorax there, you will pop into an empty space and your finger will be in air. But even if there's not a pneumothorax present, you will pop into the pleural space and you will feel very soft lung up against your finger. So you will definitely know that you're in the pleural space. Then at that point, pull your finger out. You've then got a thoracostomy, a hole in the thoracic wall, and any pneumothorax or hemothorax will then subsequently come out. The three main indications for performing a finger thoracostomy are: number one, where you believe the patient has tension pneumothorax, you've attempted to decompress the tension pneumothorax with a Turkle needle and the Turkle needle has been ineffective. For example, the thoracic wall is just too thick to reach the pleural space with a Turkle needle. Or alternatively, the patient may, for example, have bilateral tension pneumothoraces and you may only have access to one Turkle needle, in which case you'll need to use a Turkle needle for one side and an open finger thoracostomy for the other. The second indication for finger thoracostomy is if the patient has positive pressure in their chest, either via a laryngeal mask airway or an endotracheal tube, and you believe the patient has a tension pneumothorax. In that setting, the safest and most effective means of decompressing that tension pneumothorax is with a finger thoracostomy rather than with a Turkle needle. And the third indication is when the patient is in cardiac arrest following trauma and a resuscitation attempt is occurring and the chest is possibly injured. So as an example, if a patient's been involved in a significant fall or a road vehicle crash where the chest could have been injured and the patient is in cardiac arrest and a resuscitation attempt is indicated, then one of the things that needs to be quickly ruled out is tension pneumothorax. And in that scenario, the most efficient and effective way of ruling out tension pneumothorax is to perform bilateral finger thoracostomies. If we look at an alternative scenario, if a patient has put their arm through a window and has lacerated their brachial artery and is in cardiac arrest and a resuscitation attempt is indicated, that patient doesn't need bilateral finger thoracostomies because tension pneumothorax isn't part of the possible injuries that that patient may have. Performing finger thoracostomy will be a relatively unusual procedure for most ICPs. A little bit like performing cricothyroidotomy. We think the average ICP may only get to perform a finger thoracostomy every 3 to 5 years, but like cricothyroidotomy, it's a technique which could save the life of a patient. Performing a finger thoracostomy is relatively easy. I know it sounds hard and a bit scary, but it's actually a very easy technique. So in the fourth or fifth intercostal space and the mid-axillary line, so it's exactly the same landmarks we would use for preferably decompressing the chest using a Turkle needle, in the 4th or 5th intercostal space and in the mid-axillary line, we're going to make a 3 to 4 centimetre incision in line with the ribs. And the reason for making a 3 to 4 centimetre incision is you want to be able to get at least 1 and sometimes 2 fingers into the incision. The scalpel blade is only used for incising through the skin and subcutaneous tissue, and then is put down not into a sharps container because we might need the scalpel blade again. Then at that point we use a pair of forceps to dissect bluntly through the intercostal muscles, and often you will then feel the forceps pop into the pleural space. But you don't have to enter the pleural space with the forceps, but we do want to get through most of the intercostal muscles with the forceps because they can be quite tough to get through with your finger. Then at that point we put the pair of forceps down, not into the sharps container because we may need them again, and then at that point we use our finger. Now the advantage of using your finger is that your finger is blunt, it's got quite a lot of force that can be generated using your finger, and the idea is to then use your finger to blunt dissect the rest of the intercostal muscles away and then pop into the pleural space, and that feeling is very distinctive. You will know when you've popped into the pleural space. And then at that point, pull your finger out, you've created an open hole, any air or blood is going to come out of the chest. I'm now going to demonstrate finger thoracostomy using a mannequin. I've got on a pair of gloves. Now you may choose to put on 2 pairs of gloves. There is some evidence, no randomised trials, but there is some evidence that having 2 pairs of gloves will slightly reduce the risk of you cutting your finger if the patient has fractured ribs. It's most unusual in our experience to cut your finger doing this, but it can happen. So if you want to put on 2 pairs of gloves, that's absolutely fine. I'm wearing eye protection because the risk of eye splash during this procedure for those in the immediate vicinity of the patient is relatively high. So if at all possible, all staff in this setting should be wearing eye protection. I've got a scalpel blade and a pair of forceps, and that's all I need. So pair of gloves, eye protection, scalpel blade, and a pair of forceps. Having located the 4th or 5th intercostal space in the mid-axillary line, I'm then going to use my scalpel blade to make a 3 to 4 centimetre incision. Putting the scalpel blade down, because I may need it again, I'm now going to pick up my forceps and I'm going to blunt dissect through the intercostal muscles. So pop the forceps in, go in till you feel a bit of resistance, and then open up the forceps. Go in again till you feel resistance, open up the forceps. You may feel the forceps pop through into the pleural space. Then at that point, pull your forceps out, put them down, you may need them again. Now using your finger, you're going to hold your finger nice and firm, and using your forearm muscles, you're going to use your finger to dissect in a boring motion like that through the intercostal space, and you'll feel yourself pop into the pleural space. At that point, just open up the incision. So by that I mean use your finger to just make a hole in the pleura so that it's nice and wide, and then at that point pull your finger out. Any air or blood which is in the chest will then come out. I'm now going to demonstrate finger thoracostomy using a pig carcass. Having identified the 4th or 5th intercostal space in the mid-axillary line, I'm going to make a 3 to 4 centimetre incision using the scalpel blade. For the purposes of the demonstration, I'm going to perform the procedure from this side so that you can see what I'm doing. But clearly, if this was a patient, I would be on the side of the patient where I'm performing the decompression. So having found the 4th or 5th intercostal space in the mid-axillary line, I'm going to use the scalpel blade to make a 3 to 4 centimetre incision. I've used the scalpel blade only to go through the skin and the subcutaneous tissue, and I've then put it down because I may need the scalpel blade again. I've now got a pair of forceps, and I'm going to use the forceps to blunt dissect through the intercostal muscles. So pop the forceps in till you feel some resistance, and then open the forceps up. And at this point the forceps are spreading the intercostal muscles. Come out again, push in again until you feel some resistance, open up your forceps again, spreading the intercostal muscles. Pop forward again and then open the intercostal muscles. Then at this point, often you'll have felt the forceps pop through into the pleural space. Pop them down, don't put them away because you may need them again, and then using your finger, blunt dissect. You'll feel a tightness as your finger goes between the ribs. Keeping your forearm firm, you blunt dissect with your finger in a boring motion till you feel your finger pop through into the pleural space. If you're finding it difficult to pop through, pull your finger out and go back in with your forceps because you may not have dissected enough with your forceps. Go through with your forceps, pop, spread. Pop, spread. Back in with your finger with a boring motion, and I can now feel my finger popping through the pleural space. So my finger has now just popped through into the pleural space, and it's a very distinctive feel. I can actually move my finger around. I know that I'm in the pleural space, and you can see how far my finger is into the chest. And this pig carcass, the thickness, is about the thickness of the average person's thoracic chest wall. So in most patients, this is about how deep you will need to go in order to get into the pleural space. I'm now going to pull my finger out. As you can see, I've created a nice large hole, and any air or any blood is going to come out of the hole.